I'm Hank Paulson, director of the Michigan Alzheimer's Disease Center. I'm a neurologist and a neuroscientist. This talk focuses on broad strokes about the various dementias, Alzheimer's and other dementias, a little bit about the treatment, and a little bit about caregiver issues that occur. One of the questions that I get asked most often is, what is dementia, doctor, and how is it different from Alzheimer's disease? It's a very general term for a decline in cognitive function that is significant enough to interfere with one's everyday life. Now, there are lots of different causes of dementia. Of course, we will talk about Alzheimer's, but there are also reversible causes that we look for in the clinic. People who drink excessive alcohol and have poor nutrition can have a form of dementia. You've probably heard of pro football dementia or chronic traumatic encephalopathy. People who've had head injury or repetitive injuries to the head can develop a dementia later in life. There are certain endocrine or metabolic disorders such as low thyroid that can cause cognitive impairment, and there are inflammatory and infectious causes. There are many different types of dementia, and the term dementia really is an umbrella for the broader collection that includes diseases such as Alzheimer's. Today, we will focus on the irreversible age-related dementias, including Alzheimer's disease, Lewy body dementia, frontotemporal dementia, and vascular dementia. We've talked about other things such as alcohol-induced dementia or chronic traumatic encephalopathy, but today really we'll focus on these intrinsic neurodegenerative disorders. Let's begin with Alzheimer's disease. This is a very common disorder, and as you can see in the pie chart shown here, the largest piece of the pie by far is Alzheimer's disease. You can see frontotemporal dementia, the Lewy body dementias, and vascular dementia also making up smaller slices of the pie. There are almost 200,000 people in Michigan alone who have this form of dementia. Now, there are two different types of Alzheimer's, if you will. One is an early onset form before age 65, and that often can have a genetic component to it. And then the more common late onset Alzheimer's disease, which has less important genetic components. I want to highlight a point down here. That pie on the right looks very clean slices. But in reality, dementia is often mixed. We see more often people who have a mixture of Alzheimer's plus vascular, or a mixture of Lewy body pathology and Alzheimer's and vascular. It's less common to find a pure form of dementia. Now, the early onset form of Alzheimer's disease is much less common than late onset. These are people whose disease develops between the ages of about 30 and 65. And in only about 1% of all cases of Alzheimer's is it due to a specific mutation in the gene. We call this familial Alzheimer's disease, and there are three known common genetic causes of familial Alzheimer's: mutations in the amyloid precursor protein, or presenilin 1, or presenilin 2 genes. Now, people with these mutations get a much earlier form of disease. If there are mutations in the APP or presenilin gene, people will almost surely get Alzheimer's in the span of their life. And most people with a mutation in presenilin 2 gene will develop disease. Now, families that have this familial form of Alzheimer's disease are well aware of it. If someone in your family has later onset Alzheimer's disease, it's highly unlikely that there is a specific disease-causing mutation as we see in familial early onset Alzheimer's disease. Now, for late onset Alzheimer's disease, we think of this as being a disease that is both due to genetic and environmental causes. By definition, late onset Alzheimer's disease is beginning after age 65 and increases as we get older. There is one major genetic risk factor identified for late onset Alzheimer's disease, and that is the apolipoprotein E gene, or ApoE gene. There are three different flavors or alleles of ApoE that exist: the E2 allele, the E3 allele, and the E4 allele. And since everyone has two copies of the gene, there are 6 different combinations that can exist. If someone has an E4 allele, it increases one's risk of developing Alzheimer's disease. It does not guarantee that you will get Alzheimer's, but it does substantially increase your risk. So for example, these three combinations here would increase one's risk of Alzheimer's disease. Having an E2 flavor decreases one's risk. So for example, these two combinations here would be individuals who have a reduced risk of Alzheimer's. And we now know that people who have two copies of the E2 allele, which is quite rare actually, have a very low incidence of Alzheimer's disease. Far and away the most common combination is a double allele for E3. And E3 is neutral. It does not increase or decrease one's risk of developing Alzheimer's. Now, this is an important genetic risk factor, but it's not necessary or sufficient for someone to develop Alzheimer's. And therefore, we don't really use this clinically. I also want to point out that most of the studies that have been done looking at the role of ApoE in disease have been performed in predominantly white or Caucasian populations. We know much less about the genetic factors that contribute to risk of Alzheimer's and other dementias in Black African Americans or other populations. And this work needs to continue to be pursued. I think most of you are aware that the most common early symptom of Alzheimer's is frankly difficulty remembering or learning new information. But there are many other symptoms that can develop in Alzheimer's. In addition to the episodic memory difficulties, there is confusion about events that can occur. There can be mood and behavior changes, problems making decisions, or executive dysfunction. There can be, less commonly, unfounded suspicions about family or friends. And rarely in Alzheimer's, there can be difficulty with swallowing and walking, but certainly difficulties with language are more common. Now, what is the neuropathological basis of Alzheimer's? We know now that there are two major neuropathological features. They are called plaques, which are comprised of beta amyloid protein, and tangles, which are comprised of tau. Plaques are outside of the brain cells known as neurons, and tangles are inside the neurons. This is a cartoon that is certainly not an accurate depiction of what the brain looks like, but in this healthy brain region, you can see three purple neurons that look quite healthy, and there's no evidence of plaques or tangles. Whereas in Alzheimer's disease, you can see these accumulations of the beta amyloid protein forming plaques outside of the neurons, and inside the neurons you can see these squiggly little red fibrils. These are the tangles composed of the tau protein. We really at this point can see this in a brain when someone has died by autopsy. And now there's new imaging techniques that allow us to both visualize plaques in the brain and tangles inside neurons. Lewy body dementia is less common than Alzheimer's and is sometimes confused with Alzheimer's. It composes probably up to 10% of all the dementia that we see. And there are two forms of Lewy body dementia. One is called dementia with Lewy bodies, and the other is called Parkinson's disease dementia. Now, when we think about the Lewy body dementias, really they are, in a way, a merging of what happens in Parkinson's disease and what happens in Alzheimer's disease. People with Parkinson's disease, as you know, develop problems with motor function. They have tremor, they have slowness and stiffness of movements, and many individuals with Parkinson's disease will have these motor problems for many years and only develop slight cognitive difficulties. In a subset of people with Parkinson's disease, and a substantial subset, over time, they do develop significant signs of cognitive impairment and can develop what's called Parkinson's disease dementia. Now, dementia with Lewy bodies is related, and in people who have DLB, as some of us call it, they will develop cognitive or psychiatric symptoms before or very soon after they've developed the signs of Parkinsonism. And so when I say that DLB is a little bit of a blend of Parkinson's and Alzheimer's, the reason I say that is that these individuals have a definite dementia that has problems with executive function or decision-making, attention, and even memory impairment, not unlike Alzheimer's, but they also often develop Parkinsonism. The other core manifestations of DLB are visual hallucinations. They might be seeing little animals or little people in the room, often not threatening. They're clearly not real. And many times people who have these hallucinations are well aware that they're not real. Again, the Parkinsonism is common but not required to make the diagnosis. REM sleep behavior disorder, this is acting out your dreams. If someone is mumbling during a dream or moving their arms about, that is probably REM sleep behavior disorder. And the final one, which is harder really to characterize, is the fluctuating levels of cognition or alertness. People can have really good days and really bad days where they're zoned out or really fuzzy in their thinking, or they might just simply be sleepy a lot of the day. People with DLB also can have autonomic dysfunction, problems with blood pressure control, urination, constipation. They can have delusions, inaccurate thoughts about what's going on in the world around them. And they have difficulties often with visual-spatial difficulties, knowing where they are in space, navigating where they need to go. A really important point is that people with DLB or with PD dementia, we sometimes do provide antipsychotic drugs, but some of these antipsychotic drugs, which are designed to reduce hallucinations or delusions, can worsen the Parkinsonian symptoms, the stiffness and slowness that often occurs in Lewy bodies. So we need to be careful about this when someone has dementia, to recognize that antipsychotic drugs do have their place, but they can lead to significant side effects. Now, I mentioned that Alzheimer's disease has plaques and tangles with the beta amyloid protein and the tau protein. In Lewy body dementia, whether it's PD dementia or whether it's DLB, there are Lewy bodies that develop. Lewy bodies are shown right here. These are accumulations of a protein known as alpha-synuclein. Now, we don't know exactly how alpha-synuclein accumulates and how bad this is for neurons, but clearly it is a pathological hallmark of Lewy body disease. And in DLB, one finds Lewy bodies often throughout the entire brain. Vascular dementia we now recognize is a very common contribution to dementia and sometimes is the primary reason for dementia. Here it's shown that about 5 to 10% of cases, but I think the reality is many people with Alzheimer's or Lewy body actually also have components of vascular changes in the brain that contribute. This can occur in the presence of major strokes, or it can also occur without any history of strokes. Some of the same symptoms can occur as occurs with Alzheimer's, but very often there are more problems with attention, processing speed, and problem solving than there are with memory per se. There are lots of things that can contribute to vascular dementia, and I'm showing this slide in part because this is also relevant to Alzheimer's. Lacking exercise, which can lead to obesity, can increase the likelihood of diabetes, is an important thing. High cholesterol is a contributor to vascular compromise in the brain, so it needs to be treated. Smoking is bad. Those of you who have given up smoking, that's wonderful, and if you're still smoking, come up with a plan to try to get rid of that. Diabetes itself is a risk for vascular dementia. High blood pressure. We now recognize that careful, rigorous control of blood pressure is one of the ways to reduce one's risk of developing dementia. It's not really directly a cause of vascular dementia, but sleep apnea, or stopping breathing while you're sleeping, definitely worsens cognitive function. It makes people sleepy during the day and increases your risk of other diseases. So we often will look for sleep apnea in people who show up in our clinic with cognitive difficulties. And we think, of course, a healthy diet is appropriate. What exactly that healthy diet should be is not clear, but I tend to recommend more in the way of unprocessed foods, raw foods, leafy green vegetables, fruits, nuts, lean meats, as opposed to completely processed foods such as fast food or TV dinners. Now, FTD is a very interesting form of dementia. It's probably the least common among the 4 major ones we're talking about today. But in people who are under age 60, it is probably the most common. And it can occur at any age from 20 to 80, but most of the time we see it in people in their 50s. There are, again, as there is with Alzheimer's, there's a gradual decline in cognitive function, but in FTD, very often involves profound problems with behavior or profound problems with language. Sometimes there can be problems with movement or memory as well. People with FTD may experience difficulty planning activities or profound difficulty communicating with others. They can behave inappropriately. We speak of several different types of FTD, one type which is behavioral, and 2 types which involve language impairment. The FTD, among the most common dementias, is most often genetically based. Now you can see in this picture of the brain, there's the frontal lobe, which is involved in behavior, judgment, motivation, emotional control. The temporal lobe, which is involved with language and memory. And the frontal lobe and the temporal lobe, which are the ones which tend to degenerate in FTD, and hence the name. In some individuals, there's more degeneration of the frontal lobe. In some individuals, there's degeneration of parts of the frontal lobe and parts of the temporal lobe, leading to different symptoms. There are many different genetic causes of FTD, and we are most commonly likely to do genetic screening in individuals who have FTD versus DLB or AD. Now, I think it's really important to recognize that Alzheimer's disease, and in fact all these intrinsic degenerative diseases, are slowly progressive conditions. And when we speak about Alzheimer's now, we talk about a preclinical phase, a phase where individuals are not demented but do have mild cognitive impairment, or MCI, and a phase where they have dementia, which over time progresses from mild to moderate to severe. Again, Alzheimer's probably is going on for about 30 years in someone. So for example, I'm 60, and if I have Alzheimer's in my future at age 70, surely I already would have amyloid plaques in my brain, and maybe even some of the tau deposition that occurs, even though at this point I would be in the preclinical phase. Individuals who have subtle problems with memory often show up in our clinic, and we will make the diagnosis of MCI. MCI is quite common. Approximately 15 to 20% of people age 65 or older in our country have MCI. It represents cognitive changes that are serious enough to be noticed by the person or members of their family. Importantly, though, they do not affect the person's ability to carry out everyday activities. When someone is impaired in their normal functional activities because of the cognitive impairment, that is dementia. Now, MCI often will go on to lead to a dementia, and often it's an Alzheimer's type dementia, but it does not always lead to dementia. If I go back to this slide, you'll notice that some people with MCI will go on to dementia, and some people may have a very slow, stable course over time. We group MCI into two categories. One is amnestic MCI and one is non-amnestic MCI. You've heard of amnesia. Amnesia is forgetfulness. So when we speak about amnestic MCI, we're talking about people who have predominant memory problems. Obviously, if we speak about non-amnestic MCI, we're talking about individuals in whom memory is still preserved. Amnestic MCI often is a precursor to later Alzheimer's dementia, but not always. And in non-amnestic MCI, it's a little less clear. Many people with non-amnestic MCI go on to develop dementia, and many others do not. Now, as a neurologist, it's important for me to do the best I can to come up with accurate diagnosis for these diseases. And misdiagnosis can be dangerous for patients. For example, with Lewy body dementia, if we don't diagnose LBD, we might fail to give them a medication that can help their cognition, or we might even give them a medication that can worsen their Parkinsonism. I, as a neurologist, and many other healthcare professionals use memory, physical, and behavioral assessments, along with, very importantly, talking with family members and the patient to understand the changes that have occurred over time. Our diagnoses are not perfect, and they can be inaccurate, and sometimes it takes several visits for us to really determine what we think the diagnosis is. Currently, the only way to know for sure that a person has a specific dementia, such as AD or FTD or Lewy body dementia or vascular dementia, is to look at someone's brain after they have died to do a neuropathological assessment. Importantly, now there are new imaging tools that allow us to visualize amyloid or tau in the brain, and hopefully soon alpha-synuclein in the brain, and we may be able to more pinpoint diagnose someone with AD, FTD, or Lewy body dementia. We sometimes use spinal fluid analysis in the clinic, and hopefully in the near future, blood biomarker analysis to determine whether someone has a specific form of dementia. And that's important because it can lead to a different kind of care and also help the family and the patient understand what the future holds for them. Now, when we think about treatment, I think many of you probably are thinking, what about the medications? And I've listed it here toward the bottom because really I think there's so many other things that are involved in treatment of dementia. But there are medications that can enhance memory. There are several different categories that we use them in patients. There are no medications yet that have been shown to slow the progression of Alzheimer's, Lewy body dementia, or FTD. Importantly, vascular dementia, because it's associated with diabetes, hypertension, hypercholesterolemia, and smoking, is something that we can improve or reduce the progression of by making sure we treat those other diseases and symptoms as well as possible. I say to everyone who comes into my clinic who I diagnose with dementia, don't let this disease own you. You own it. You still have a life to live. And yes, you may have cognitive impairment, but you're still the same person. There's so many things you need to do to help your brain function as well as it can. Physical therapy is critical. In individuals who have language issues, we use speech therapy. We think it's critically important to have support groups and social activities to keep your brain working as well as possible. And our own center supports many different support groups for dementia, including Lewy body dementia. And occupational therapy can be very helpful to individuals who are having difficulties with some of the skills at home. What can you do to lower your own risk of developing dementia? There are many different things that are relevant here. People who've had a greater degree of education and whose jobs have required lots of intellectual challenge are at lower risk for developing dementia. Now, if you're my age, 60, you've already had your education, but you can continue to keep informed and keep your brain active. I think this is critical. Cognitive and social engagement is so important to continued brain function. And I think it helps people who are aging, whether they have dementia or not. Obviously, doing what you can to avoid brain injury. And of course, we've talked already a little bit about chronic traumatic encephalopathy, or as some of you may have heard of, the pro football dementia. We really want to reduce the concussions that someone has early in life. I cannot emphasize enough how important sleep is. We need enough sleep so that we're not tired during the day, so that we can attend to tasks. And having enough sleep and the right kind of sleep also reduces risk for other diseases. So if someone has difficulty sleeping or has obstructive sleep apnea, it must be treated. And again, cardiovascular disease. There's so many things that contribute to that. Diabetes, hypertension, hypercholesterolemia, these need to be treated as well. One thing that's not on this slide, which I think is critically important, is exercise. Data show time and again that aerobic exercise, probably 3 times a week, 30 to 45 minutes a time, are really important things to do to keep your brain and body healthy. So that if you can exercise, if your body is capable of doing so, I encourage you to engage in aerobic exercise, whatever that might be. Let me finish on a very important point, which is that, of course, when we talk about dementia, we're thinking about the person who has it. But the reality is, people are caring for that individual who has dementia. Caregivers or care partners can be family members or friends, or they can be professional caregivers. I already mentioned to you that almost 200,000 people in Michigan have dementia. Look at this. Over 500,000 people are helping to care for those. So many people are affected by dementia. A national poll on healthy aging showed that there are a lot of challenges for dementia caregivers. I'm going to focus on this point over here. How stressful and rewarding is dementia caregiving? Well, it is stressful, very or somewhat stressful in almost 80% of individuals who are asked. But it's also rewarding, very or somewhat rewarding to provide care for those who have cognitive impairment or dementia. So when you think about someone with dementia, also think about the person who is caring for them. In the clinic, not only do I ask how the patient is doing, but I'll turn to their caregiver or care partner and say, how are you doing? What can we do to help you? Check in with those who are caring for those with dementia. See if you can help them. Provide them support in the ways that you can. Sometimes it's simply saying, what can I help with? You ask that question, they may be able to come up with a way that you can help them. And remind them that what they're doing is important and hard, and we're all grateful for that. Now, a final point, and I think this is maybe the most important slide in this entire slide deck, is that people who have dementia are still the same person. A person with dementia is still themselves. They may have lost some skills, but they're still the person deep down. And I think it's very important that we remember that as we interact with people who have dementia, as we help them. In Alzheimer's particularly, although memory may be profoundly impaired, usually the person can still hear and understand a lot of what you're saying, and they want to engage with you, so please do that. People with dementia, even when they have profound memory issues or problems with decision making, still enjoy a sense of purpose. Finding things that they can do and can do safely is an important way to help them make sure their brain works as well as possible and that their time is good. Remember to focus on abilities, not the disabilities. I am reminded of one of my favorite painters, and Willem de Kooning was a brilliant painter in the 40s and 50s. You may know his paintings from the angry women paintings that he did. They're beautiful. But when he was older, he had profound dementia, and he was still painting, and his paintings were still spectacular. He still had the ability to paint, despite the fact that he'd lost his cognitive abilities. Speaking of which, there are a lot of things that people with dementia may like to do. We, in our own support groups and in some of the activities we do in our wellness initiative, try to get people to get involved in the arts, whether it's painting or singing. Baking under supervision can be a wonderful way to get people involved. And this ties in with the importance of exercise, going on walks with people who have dementia. Most people with Alzheimer's can continue to walk quite well till very late in disease, and we strongly encourage vigorous walks with friends and family. I'm glad that you listened to this talk. There are lots of reasons why it's important for you to know. Alzheimer's is not going away. It's the 6th leading cause of death. There are 5.8 million Americans now living with Alzheimer's, and that's going to go up to about 14 million by 2050 because we're getting older as a population. 1 in 3 seniors dies with Alzheimer's or another dementia. If you have experience in your own family, you know this. But whether you have or not, there are so many people who could benefit from your help. I'm going to stop there. I want to thank you for listening. And if you enjoyed what you heard or you have recommendations for us, we'd love to hear from you. Thank you very much.